Welcome to Caring.
Welcome to Caring Well.
Welcome to Caring Well.
Welcome to Caring Well.
Caring Well. Welcome to Caring Well.
Welcome to Caring Well.
Hey, welcome to Caring Well, Middelton Pediatrics podcast, where we discuss topics to help you care well for your child. Today, we have a great conversation with Dr. Troy King. He's a longtime pediatric dentist. Many of you, I'm sure, already know him, but tonight we're going to talk about a lot of different topics to help you care well for your child as it relates to all things pediatric dentistry. So let's go to that conversation. Troy King, welcome to Caring Well. So glad to have you.
Thank you for having me.
Yeah, we're going to get into a bunch of pediatric dental issues, but just as a way of listeners getting to know you, I'd love you to tell a little bit about yourself.
Love to. Thanks for having me.
Yeah.
Appreciate the opportunity. I was working at the YMCA in college and really found myself enjoying working with kids. My girlfriend at the time, who's now my wife, was also working there. And when I got into dental school, she said, you should think about kids because you're so good with them at the YMCA. And I said, well, I don't want to stay at any more school to limit myself to one population. And she said, well, you probably should because you're good at it. And I said, well, I don't really know if I want to do that. And then I thought about it, prayed about it, and it was certainly something that I thought that if I could get the opportunity to do it, I think I would like to do it. You know, my worry was that if I applied for the position and didn't get it, I might be embarrassed. Despite doing pretty good in school, I still worried about things like that. And she said, well, just don't tell anybody you're applying. It was very, very practical on her part. I said, well, that's a great idea. She said, that way, if you don't get in, nobody cares because nobody knew.
And this was all in Louisiana?
This is all in Louisiana. Did all my residency training at LSU. And then when Christy and I were deciding where to move, we got married. And before the residency, I had to decide where I wanted to go. And I looked for jobs in Louisiana and was finding really an unwelcome population for what I was doing, almost as if there were too many of them there. And we started talking about Florida. And then we started looking around, and I visited many cities in Florida and started just cold calling pediatric dentists and found such welcome response in this area that I said, we got to go check it out. And so I ended up flying here on multiple occasions and meeting with many practitioners who were established. And they said, you can come anywhere. I mean, there's kids everywhere. There's no pediatric dentists. We need you yesterday. Get down here as soon as you can. And I was like, wow, that's really different than where I was. And so just looked for a developing community that was growing and put our flag out in the way of that development. And we were in Oviedo before the mall was in Oviedo. And I think we've outlasted the mall now.
Yeah,
It's in Oviedo. And so it's been a great place to do what we do, a great place to raise our kids, a great place to be involved with. You know, I did find it a little bit difficult to give parents advice on their kids without having children of my own. And I got over that quickly once we started having kids because there was a pretty rapid pace to which we were doing that. Ultimately ended up with 16 kids and you know, had then a lot of things to say to parents about,
Right.
This is what I would do with my kids.
It's quite a catalog of experiences, Dr. King.
And good and bad. I got to tell you, I live it with my kids and my patients, you know, and it's nice to have at-home experience with the issues that our parents face too in our practices, you know, tooth decay and trauma and all those things that happen to your kids happen to my kids. And so
you've been in Oviedo the whole time?
Been in Oviedo the whole time as a sole practitioner. Decided early on that I would really like the idea of working independently of corporations or insurance companies and all that stuff. And so while we work with many insurance companies and do those things, we've maintained our independence from corporations and that kind of influence. And also I've been, you know, often looking for other practitioners to join the practice. We've had other dentists in the practice for short periods of time. In dentistry, a lot of us are very entrepreneurial. And so we get out, we see how to do it, and then we go out and do it. And so that's something that we do have to just figure out, you know, over the years. Fortunately, I've got a good staff. And so we're able to take time off and do the things we need to do.
Is there any simplistic way to say how commercial insurance in dental world is different than it is in medical?
Yeah, absolutely. And I think this is, if I could get the message across about how it differs, is that health insurance at its core is true insurance. You're insuring against the potential of a great loss. So in other words, I choose to pay my insurance company a certain amount of dollars a year to hopefully minimize the impact of a heart surgery or a brain aneurysm on my child or myself. And that's a big ticket item that needs insuring, or else you're gonna go bankrupt. In dentistry, we see the insurance companies as, instead of insuring against large numbers like that, they have maximum allowable benefits, they call it. And so they may cap annual benefits. The most they'll pay out for dentistry in any one year at $1,500 or $2,000. So that it ends up not being really insurance at all. It's more almost like a discount or a coupon. And I think that if you had the mentality that, okay, that's what it is, and that's all the insurance companies are offering. They're not offering what they offer in the world of pediatrics. You can't find a policy that you can pay for and pay a certain amount a month, and then after the first $500 out of your pocket, they'll pay the rest. Doesn't exist. And I wish it did, because it'd make it easier for us. But the fact that it doesn't, and then they call it insurance, and then parents are used to what insurance truly is with you guys, it's confusing. And so, again, a lot of our time is spent educating and trying to allow the parents to, help them decide what's the best way to go about maximizing their benefits, and at the same time getting the care that they want. Because insurance carriers will try to kind of steer them towards places that are more favorable for them. It's understandable. It's more profit for the insurance companies. And that's okay. But again, it's still free market, and you get to choose where you go and what you do. And so we like that part of it. So just trying to maintain for the parents an option to get the care that they want and hopefully still have it be affordable.
Well, what are tips that you are regularly sharing, or maybe would love to share with patients more about how to get the arrow pointed in a good direction when caring for the teeth of infants, toddlers, preschool kids?
Perfect. Good segue, because that's exactly how we like to see it. We like to see them early. From a parental standpoint, to start early, getting familiar with your kid's mouth and getting them used to you being in there. I think that, as far as caring for teeth and gums, before teeth even arrive, you can be wiping the gum pads with gauze or the corner of the bib or what have you, getting, stimulation to those gums. And when the first teeth are emerging, certainly starting with a soft bristle toothbrush and brushing them. I think consistency and time and place make all the difference for kids. We like them to have something that they can anticipate so that they seem to fall in line better with what you're trying to accomplish. So by that, I mean, we have a routine. He's going to get a story. He's going to get a bath. He's going to get prayers. He's going to get a toothbrushing. It's going to all happen in the same order at the same time, and allow him to start understanding it's just part of the routine. And
I think there's something in the AAP that's brush book bed.
Okay. Yeah. There you go.
Like that. Yeah.
And I could say, hey, I invented that, but I just didn't write it down. Right. And so, but what I've been telling my parents is that the more you can give that child a predictable pattern at night, the more cooperation you're going to find. And so I think having it in the same time, same place, and the same person makes sense. But then as far as physically what you're actually doing, in essence, all of what we deal with in pediatric dentistry, most of it can be prevented if the bad things, decay. That's the main thing we deal with. And it's still the number one infectious disease in the country, more than ear infections and throat infections combined. And so we do have to continue to preach and teach about it. Removing the plaque becomes the biggest part of what you need to do. You'll talk and hear about fluoride and this and that is controversial. Removing the plaque from the teeth is not controversial. You have to get plaque off of the teeth. And as they're younger, plaque sticks to their teeth. You remove it with a toothbrush or any type of physical wiping of those teeth. And that's the main reason you brush their teeth, not to put fluoride on their teeth. Those other things like fluoride, toothpaste, and rinses and all that are adjunctive and can help to mineralize the teeth, but it won't help if plaque's constantly being left on the teeth. And so plaque removal, when you're young like that, I think wiping like we talk about, starting to introduce a very small amount of fluoridated toothpaste is advisable, a rice grain size until they can spit really good, which is usually going to be for girls about 3 and boys about maybe 3.5. And so if they can spit really good, a pea size would be appropriate. If not, still a rice grain size twice a day, and them swallowing that with probably fluoridated drinking water is not going to be too much fluoride from what we know.
And the limit, just to be clear, the limitation of the amount of toothpaste is because of the fluoride.
That's exactly what it is. Now, if you want to bulk it up for flavor and all that, then use the toddler toothpaste that has no fluoride over the rice grain size of fluoridated toothpaste.
So pre-teeth eruption.
Yeah, wiping teeth. And
Wiping gums.
As far as massaging, getting in there, making sure that you're doing it in a way that's engaging the kid. Let's do it after we feed them a bottle. Let's kind of make it, be like it's going to be when they're eating and things like that. Obviously not putting them in the bed with a bottle once teeth start arriving. You don't want them in a crib nursing with a bottle with teeth, falling asleep, waking back up, having the bottle, having access to calories at night while their saliva is not flowing that quickly can be damaging. Nursing on demand can also be damaging. And so you got to be conscientious of those things once you start getting teeth and start having habits that could be detrimental to the teeth. Again, if you're removing the plaque, it makes these issues a lot less concerning.
So if you had someone that was committed to being A++ parent.
Yeah.
Are you saying some type of wipe down of the gums after every time they nurse?
I would try.
Okay.
Yeah, I would try.
And they should take all of how long?
10 seconds,
Okay.
10 or 15 seconds. It's a twofold benefit. Number one, plaque can actually accumulate on those gums and it's not going to damage teeth yet because there's no teeth there, but certainly inflammation and things like that can happen. And we don't want more bacteria in our mouth and access. Plaque is sticky. So if then the parents are feeding, tempering food, testing items for their kid and inoculating them with their bacteria, it'll stick more readily to plaque and areas like that. So that's, the strep mutans transmission from parent to child is not it's well documented, well understood that that's generally how we get that bacteria to our kids that's responsible for decay.
Is the bacterial component of tooth decay still just one bacteria?
Strep mutans is the main culprit. Yeah, there's other small ones that get in there and do things, but that's the one that's the main culprit, if you will. And then as they move past toddler and they've got teeth, we need a toothbrush, soft bristled. Fluoride toothpaste would be great. I think it would be advisable. Would it be totally necessary? No. If you remove the plaque from the teeth 100%, then theoretically there can't be decay.
You're saying that because fluoride is really, well, it's helping remineralization, but it's also preventing demineralization somewhat.
Right.
But you're saying if you remove plaque, you're not starting the process anyway.
Right. So they have a circle diagram that they show in school, and it's got 3 circles and it's tooth, substrate, and plaque. And so when those 3 rings hit, in the center is tooth decay. And so you take one of them out and you just can't have tooth decay. If there's no tooth, there's no tooth decay. If there's no plaque, there's no tooth decay. If there's no calories to feed the plaque, there's no tooth decay. But again, twice a day, removing the plaque, usually twice a day is because we expect that you're not going to do it perfectly each time.
Right.
Theoretically, it takes the plaque matrix 24 hours to form.
Yeah.
So if you do it perfectly once a day.
Is there a way you teach appropriate pressure?
So the method, once you start getting teeth that you're teaching kids to brush, we're showing them and trying to get them to hold a mirror and look at it. And in essence, they're doing what we call a sulcular scrub technique, where they're trying to do gentle circles, not scrub back and forth like most kids want to do. That's mostly to help make sure their gum tissue doesn't get kind of eroded. But the pressure, we tell them, is kind of like you're trying to wash a window, like you're trying to get stuff off a window. You can't just pass the brush over your teeth. You have to actually scrub them. And it takes 2 minutes. And I think that as opposed to showing them pressure, letting them know that it takes 2 minutes to brush your teeth gives them the thought that, okay, it seems like I can do it in 20 seconds. Why 2 minutes? Well, it's 2 minutes because you're not getting anything off in 20 seconds. You have to scrub like that. So
do you think the more common mistake is too little pressure? And again, avoiding the gums, that's a different deal.
No, it is too little pressure because even nowadays with the soft toothbrushes, it's hard to find a toothbrush that will actually damage your gums. So go to town, be firm, with a soft bristle toothbrush. The dental floss should start as soon as the teeth are touching. Anytime the teeth are touching, dental floss should be introduced. Once a day has been shown to be adequate with flossing, whether it's at night, in the morning, it doesn't matter. It's just happening once a day is the most important part. Always get into discussions with adults or teenagers. Should I floss before I brush or brush before I floss? And I think it's a discussion that we all have, and it's a fun discussion, but it doesn't matter. You do what feels best to you. I think logically, if I'm going to brush my teeth and then put floss in there and pull stuff from between my teeth and get it all over my clean teeth, that I've just kind of, tracked mud back in the house.
Mm-hmm.
So I like to floss first and then brush.
Are there electric toothbrushes in the King home?
Yes, there are. And I wish all of my kids, one of my wishes for my teenage kids as they go from toddlers to teenagers through my practice, one of my wishes would be that they would ultimately get to an electric toothbrush by the time I graduate high school and be flossing every day. I'd be very happy if my patients were doing that. And it's one of those things that I think would give them the best chance at a good, healthy dental life going forward. If they flossed every day as teenagers and then into college, that would springboard them into adulthood in a way that I think could help get them excellent dental health for a lifetime. And I tell parents, start off with a vibrating toothbrush that just maybe oscillates or vibrates a little bit.
Right.
And then as they get more permanent teeth, maybe you get into something that's a little bit more like a Sonicare type toothbrush that has different settings on it.
Mm-hmm.
But usually that's going to be 10, 12, 13 years old before you get into something that intense.
What about, they probably aren't called this anymore, but water pick systems instead of flossing?
Yeah, so the water flossers are great for braces to give kind of a cleaning, if you will, but nothing will separate the teeth like the string, like the dental floss. And you have to get that separation because it's at the contact point where the plaque matrix forms. And that's where the decay forms, is where the tooth touches. And unless you actually break contact, it's not going to be effective. Now, the water flossers and stuff, if you ask me, well, if I'm not going to floss.
Right, better than nothing.
Absolutely, it's better than nothing. It stimulates the gums. It gets debris out of there. And the massaging action of the gums can help keep inflammation down. It's just not going to have the reduction in the plaque matrix and then the decay fighting capability that the dental floss will.
I mean, saliva is playing a role in this, right? I mean, a beneficial role.
Absolutely, and especially in mineralization. And so, and DN remineralization.
Right.
And so that's the big battle. It's like a bone. Teeth are not just inert. They're either losing mineral or they're gaining mineral. And so when you think about what your child's doing, you can get a pretty good idea of whether he's gaining mineral or losing mineral in his teeth. If he's following a strict parentally guided diet and hygiene regimen, he's probably keeping his mineral balance pretty good in his teeth. But I like to give this talk about my kids who are close to teenage years or maybe even teenage years to my parents, because it happens in my house and I see it playing out, and these kids will be cruising along until they get to 14 or 15 and having no tooth decay. And then all of a sudden it's like little bombs are going off in their mouth. And the mom's like, I just don't understand it. And I say, yeah, I'm wondering if it's like in my house where my 15-year-old puts me to bed at night in the summer and then stays up who knows how long, eating who knows what. Did he brush his teeth before he fell asleep playing his video games? I don't know. He went to bed at midnight because it's summer. And then he woke up at noon. Did he brush right when he woke up, or did he go to his friend's house? And so, you've got a petri dish of things that are happening that now you don't have as much control as you did when you were kind of advising him, if you will. And so I tell parents, just establish with them, look, okay, I know I'm going to bed now at 9 o'clock and you're not going to go to bed, but I need you to brush your teeth now. Like, just brush them now before I go to bed. I know you're going to probably eat or something later, but I want to see you get that brushing in.
Is there an age at which you expect relative independence?
Yeah. And so that's a good question, because we ultimately have to get them to take responsibility. As parents, we have to transfer the responsibility in a prudent way that doesn't put them at risk, but also doesn't, risk having them be over, treated by their parents. And so I think that when you think about brushing and flossing, they're not going to be able to floss digitally, with the dental floss. They can use little floss picks when they're probably 6, 7, or 8, but handheld dental floss, I think 10 to 11 or 12 years old even, it's going to take some dexterity to do that. As far as brushing goes, once they hit kindergarten, I let them brush in the morning by themselves. And then at night, it's kind of a team effort. Okay, kindergarten, Tommy, go brush your teeth. We got to get off to school. Great. I hope you did a good job. I'll find out tonight when I check, and so then at night, okay, you go brush, then I'll finish up. And then you can kind of take inventory and see
You're
how
doing
they've done.
exams at night. You're
Yeah.
not just participating.
Yeah. I want to see until I then give it to them. And usually what I'm finding is it's a dangerous time to give it all to them between 6 and 8 because they're starting to erupt their permanent teeth then. And so it's when most parents want to give it to them because they've been doing it for 6 or 7 years. It's like, please just brush your teeth on your own. But now they're starting to get permanent teeth. The stakes are high.
Right.
And when teeth first erupt into the mouth, they're not finished calcifying. They're not quite finished developing. And if they have plaque on them all the time because it's not getting removed effectively, they're going to be weaker long term.
So more vulnerable in early.
That's right,
Yeah.
early development. So my best recommendation is to get the kids from 9 to 10 years old until you start handing it over to them. At least have some once a day
You'd
supervision.
rather them be independent at 4 and 5 than you would at 7 and 8.
Yes.
Yeah, because
Exactly. And so I think that, and then when you pose it to parents like that, look, if you put those few years in of supervision, some nights I'm not even brushing them because they're doing such a good job. But other nights it's like, you didn't really even do it, did you? Yeah, you're right. Okay. So I think just the accountability is big. If you would let them wash the china by hand and put it away and feel pretty confident that it would make it to the cabinet, they're probably ready to floss and brush on their own. But if that would be a dicey proposition for you, then you probably should still at least supervise them once a day.
good test.
Yeah.
Do you end up doing a lot of dietary advice?
Yes. And a lot of what we do is just to try to get parents and kids, more importantly, as they get older, to understand that what they're eating and drinking is affecting the environment in their mouth. And really we try to take the dietary thing to an acidity talk, right? And it really is all about that for us. Interesting biochemist dentist who was noticed in a patient population of his in one particular practice, extremely decay riddled. And when he talked to him and was taking strict dietary, histories and all that, he found that they were eating some of them were eating a lot of sticky candy, but some of them weren't. They were eating goldfish and crackers and cookies and things that didn't seem carcinogenic, sweet to him. And so he started focusing some studies on this and finding out how quickly some of these things turn to sugar on your teeth and how sticky they actually are. And so you can look it up. I forget his name, but he says anytime he gets a kid with cavities that has these snacking tendencies, he tells them for 6 months, okay, we're going to fix these cavities, but for 6 months, you can't have any treats except chocolate or ice cream. That's all you can have. And the kids are like, I can have chocolate and ice cream? Okay.
Great.
It's satisfying. It's filling, but it melts. It goes away. It doesn't stick. It's not carcinogenic. And he says, he's finding incredible success. And so I kind of like to look at things like that and go, okay, that challenges me to say, what are we doing in this diet that could be modified, but not strip you of your childhood, right? And allow you to have less experience with tooth decay. And I think things that aren't sticky and things that aren't acidic and things that aren't spending a lot of time in your mouth or on your teeth are going to be beneficial. And I tell kids, if you have a drink of soda during dinner, it's far less problematic than if you have a can of soda while you're studying for a test, because you're going to spend more time while you're studying sipping on that and giving the acidity longer to work its damaging effects on your teeth. Whereas when you're eating, you're already salivating, buffering acids out of your mouth from your food, and it's not going to be impactful at all on tooth decay if you're doing it like that.
Go back to the young ones for a second.
Yeah.
Pacifiers and thumb sucking and any comments on that?
We see the impact of pacifiers a lot. And, I think what I love seeing is cooperation between our academies. When the Academy of Pediatrics and the Academy of Pediatric Dentistry thinks the same way about things, it makes me smile, because it's not always the case with other entities. As far as we seem to be on the same page, we know that they're helpful for reducing SIDS. They're helpful for premature infants in developing a sucking reflex. We do know that after they've been around, though, after a year, if you're using them after a year, they can increase the incidence of otitis media and things like that. And so I think that they have a place. Our academy supports parents in their desire to introduce it. We think that if you introduce it for soothing reasons, nurturing, that kind of thing, certainly can be helpful. It can again, reducing the incidence of SIDS is enough for most parents to say, yes, I need to do this. But I think starting to coach them afterwards, that after one, you probably are losing those benefits and starting to pick up some bad stuff, not only from the aspect of getting more ear infections and stuff, but also from oral facial development. After 18 months of age or so, you're starting to impact that. Not that you're, irreversibly impacting it yet, but you're starting to get changes that then, if carried for another year or so, could become deformities that require more orthodontic intervention down the road. So my best recommendation for most parents is, if you can get them to get off of it before those bad things start happening, that's a good idea. If you find yourself in a situation where you've got a 2-year-old and you're about to have another baby, I get it. I mean,
Right.
You got to kind of pick your poison. I understand. Generally speaking, the cutoff for me to say, okay, if you stop dentally, you're not going to have any major impact, is probably 3.5.
Is there a standard time you recommend kids be seen by an orthodontist, or is it just based on your evaluation?
Yeah, usually it's something that each kid is going to have a need differently. And so I think for us, we're seeing them so often, kind of like you're going to spot something if it's needed to be seen, probably before any recommendations of normal academies or something might recommend. So I want to say I've heard from the orthodontic societies that maybe 7 or 8, they should be screened for that. But fully recognize that if your kid's being seen by a pediatric dentist, 20% of my training was orthodontics. And so we're kind of doing that every time we see the kids anyhow, and mentioning things to parents early on, and then ultimately quarterbacking and pulling the trigger based on their individual growth and development. So I get a lot of parents asking me if they should be seeing them. I go over why they either should or shouldn't. And then it's up to them ultimately if they decide to do it.
Yeah, but
we'll
it does
support them whatever they do.
Speak more to what you were starting off with, just needing a home where someone is guiding you.
Right. And, in the orthodontic world, oftentimes this comes not from the parent's concern for their kid, but for the social pressure of, well, I see all these other kids with expanders, and I want to do the right thing. So are we doing the right thing? And so I think that once we tell them, rest assured, they wish they were you,
Right.
They're probably doing it
Not
because there's a
having to.
bite issue and they have to do it. It's not a vanity play at this point. It's very rare that before the age of 13, there's going to be vanity reasons to undergo orthodontics. Now, there are some, and confidence and things like that are real concerns for some kids.
Sure.
When the malocclusions are grotesque, but that's more rare than bite concerns. And bite concerns are fairly common these days. And so we're finding a pretty healthy need for early intervention, in orthodontics.
You get asked about teeth grinding?
Yes, a lot. Many, many factors, but when you boil it down, I think we come back to allergies, normal growth and development, and stress. When you talk about allergies and what's going on with their ears and eustachian tubes and all that, there could be some validity to the thought that they're trying to, adapt or equalize or balance the, what might be going on, what might be an imbalance perceived by the kid, nature's own attempt at equalization or fixing it. And so I think that understanding that some of these processes might be just kind of normal is okay. And so it doesn't always signify that there's a problem and your kid's going to have big issues down the road and have TMJ. That's a big, big thing. And so it's very rare that we find kids that cause enough damage to the dentition to need intervention.
Whitening products, it's actually not even just products, because if you just look at the aisle, and just look at toothpastes.
Yeah. So no charcoal toothpaste, please. Very abrasive, very effective. They get stain off your teeth, but they also get enamel off of your teeth. And so you don't want to do that. I think the best thing to think about whitening is, and it's kind of counterintuitive, actually the best age to whiten tooth enamel is probably about 14 or 15. And so most people be like, well, is it safe? Yes, it's safe. Crest pioneered major studies on whitening before they brought it to the market over the counter. And suffice it to say, they've survived 25 years of over the counter whitening because it's safe, not because it's causing a bunch of damage and people are suing them. It's just not happening. And so when we talk about it, I think the most important thing is prudence with it. Like anything, you want to use the lowest amount of whitening that gives you the intended result that you want. And so as a parent, I would have to say, don't let your teenagers go unsupervised with doing this, and maybe talk to your dentist about, is there something in the office or at home that they can do that's safe? And I tell my kids all the time in the office, the Crest white strips work wonderfully. And it's a very, very easy and cost effective way to whiten your teeth and truly whiten your teeth, not just gloss them with toothpaste that's sometimes laying down titanium dioxide on your teeth and making them look whiter because now they've put something on there. Most parents are shocked that it would be safe for their 12 or 13 or 14-year-olds, but very happy when they see that the results can be pretty dramatic at that age, because the discoloration that you see with most of the time with kids that age is exactly what that agent is meant to change. It's kind of an oxidation reaction at the surface. A lot of them are hydrogen peroxide in whatever form it's in that causes the change, and it's actually real change. And then you might have to redo it in a year or 6 months or
so you're not
or 2
discouraging
years.
them. I think it is hard, the idea of being a wise consumer. I mean, how do you look at levels and things like that?
I think
That's
stick with
easier
tried
said
and
than-
true in that arena, and you'll be very happy, because there's a lot of things you can find on Etsy or whatever these other sites are. I don't have the social media, but I know there's tons of people showing your kids how to whiten their teeth. Crest brand white strips, I don't get anything from them, but I get positive results for my patients. For the ones that have difficult staining, first of all, you got to make sure that there's not extrinsic staining on their teeth. They need their teeth cleaned, and to make sure there's not actual plaque or tartar on their teeth before the impact will be seen. But once you have that understood, by all means do it. If you're having trouble seeing any changes, then talk to your dentist and see, is there anything you can do? We do now have whitening gels that we can use, that we actually use in the kids' retainers now. So it used to be that we would make these mouth guards. It was real expensive. The movie stars would get it. Well, now these kids have these clear retainers, and Opalescence has come out with a gel that's compatible in the retainers. And so we show them how to inject it into their retainers and do it safely. It's a much higher efficacy than what Crest white strips would be, but it's obviously supervised by a dentist. And cost-wise, it's not that bad. It's $100 or so, whereas it used to be $1,000, right? And so I think now that's one place where technology's helped us out.
Let's shift gears to tooth trauma. Some things just to know for the parent as far as what's emergent, how to handle tooth trauma, some of the more common ones. Not talking about motor vehicle.
No, I understand. Yeah, because the ones that happen every day are the ones in the bathtub and on the playground and all that. And you want to be well equipped as a parent to help your kid as much as you can. And I think the first thing to understand is that when they have trauma to their mouth, the first thing you got to do is just soothe the child. Like, make sure that you're getting that child to be as comfortable as they can be before you start digging in their mouth. I mean, if they're obviously not choking on a tooth that's been dislodged, you see some blood in the mouth, soothe them first. Don't you go straight to the mouth and they're looking at you and you got your hands wide open and you're starting to show your face on how upset you are. The kid's going to feed off that. So just soothe them and let them know that everything's okay. Maybe even get them a popsicle, But the main thing to realize is that any oral trauma is going to be looking worse because of all the saliva in your mouth mixed with blood. It makes it look like it's a lot of blood. And often it's from a very small tear and some oral tissue or whatever. The mouth is very well vascularized. It's the beneficiary of being very close to your brain. And so a lot of blood supply in there, things will bleed a lot. The main thing is to find out if any teeth have moved out of position. It's the first thing I would do. Once you get to where you can assess, if you can see through blood or what have you, that no teeth have moved out of position, then you can collectively take a deep breath and realize it's probably not going to be as bad as you had thought. So first thing, kind of a general assessment. If there's not a lot of teeth in there already, let's say they're 18 months and they're just starting to walk, their heads are big, their balance is not great, they catch themselves with their heads at that age a lot, they're probably going to strike their mouth. Their teeth will probably not be too accessible for damage because they're still covered up by a lot of lips and gums and things like that. But you may tear the frenum attachment or some tissue like that. And so, again, pressure on the area that's bleeding, recognizing that if no teeth have moved or there's no major lacerations, then it's probably something you should call your dentist at the dental home about. You certainly don't need to go to the walk-in clinic or the emergency room for that, unless there's other medical needs you think, if it's something that could lead to a concussion or something.
Right.
Certainly deal with that
Non-dental,
first.
Right.
But as far as dental, evaluate. If no teeth have moved and there's no large lacerations or cuts or anything, then certainly I would say consider a visit to the dentist the next day if it's after hours, or maybe that day if you feel more comfortable. And usually the exam at that point would be to determine if there's any possibility of fractures of the supporting tissues of the teeth. If the teeth are in their regular position, but they are mobile, if one moves, that's probably a good sign that you might have had a root issue, broken root, so probably should be seen that day for that. If you call my office after hours, it gives you my cell. It just says, hey, call the emergency number, and that's my cell. So I think that is a great thing because since the advent of iPhones, we can triage this over the phone. Hey, Mom, send me a picture. I'll call you right back. And it's such a great and effective way to figure out what's going on.
Let's stay on the one that nothing is broken and nothing is removed, but maybe it's movable. What are you telling them in terms of how to care for it, dietary and all that?
So soft diet, cut their food up, ibuprofen right away. Make sure that for them, they don't challenge it. Parents ask if they need to tell them. I say, no, just cut their food up and give them the opportunity to eat it that way, because he's not going to chew on that tooth if it's sore.
Right.
If he sprains his ankle, you don't have to tell him, hey, you need to
Stay
limp
off
now.
it, right.
Yeah, he's just not going to walk on it. He's going to limp. Same thing with his tooth. If it's concussed enough to where it bothers him, he's not going to chew on it. So give him the opportunity to eat by cutting his food up, soft diet, usually a couple of days of that, and then the teeth start quickly tightening back up.
Then what about a broken tooth, partially
fractured baby tooth? You need to take a picture of it, try to find the piece if you can. We want to make sure it's not embedded in a lip or a tongue. So if you have the piece, we like you having the piece, not to try to put it back, but just to kind of make sure it's not somewhere else.
Somewhere else, yeah.
And on baby teeth, if you knock the tooth all the way out, we don't reimplant baby teeth. The damage that it can cause to permanent developing teeth and the gums is too great of a risk. So with a totally avulsed baby tooth, you leave it out and generally be seen to make sure there's no other fractures or what have you. With a permanent tooth that's knocked out, if you have access to milk or formula, place it in milk or formula right away. Touch it by the crown, not by the root if you can. Don't put it in water. It'll burst the cells that are on the root. Be better to keep it just in maybe a moist paper towel instead of submerging it in water if you don't have milk. But milk you can usually find, or formula. If you're at a baseball field, there's got to be somebody with a bottle or something or something. And then time is of the essence in that one. You call your dentist. If he doesn't answer, you call him again. And usually we're astute that those things need to be seen right away in our office. And generally, we're going to reimplant that tooth and try to splint it and get the permanent tooth back into its position. And then ultimately take care of the nerve and things like that.
What is your time window there?
Yeah. In milk, 6 hours. Much easier within the hour. the success rate skyrockets if you get it reimplanted in the mouth within the first hour. And the best medium, but we don't trust our kids to do this, is in their mouth. So, you knock it out. I mean, like, you don't want them to swallow it. So, but saliva or isotonic, solution would be the best. But milk is great.
Let's go back to the fluoride supplementations. It is so much in the news. So Seminole County just voted to remove it.
Yeah.
There's a Senate bill right now for the state that will now pass the Senate, will now go to the House, potentially making us the second state in the country to remove fluoride supplementation from drinking water. So anyway, just speak at least to Troy King's take on all this.
Well, first of all, start with the state, because our Florida Dental Academy Association is very involved from the standpoint of public health and trying to offer the greatest evidence-based, research and advice to help the public's dental health. And so I think that they've been there every lockstep trying to avoid, having fluoride removed from the water, because, it's been shown you can get on the internet, find what you want to find. But there's over 3,000 published refereed journal studies that prove the safety and efficacy of fluoridated drinking water. The neurotoxicity studies that most people are concerned about all involve at least twice the recommended dose. And so, again, I think you have to, as a parent, look at those things and decide what to believe. But recognize too that you can't make these decisions in a vacuum. So you can't just be like, okay, fluoride's bad, so I'm going to not use it. And then that's it. It's over. Like, that's not the end of the story. You're choosing to not use fluoride, and so you're thereby choosing to have a greater risk of tooth decay. It's just that simple. And that's okay if you know that that's what you're choosing. But I think when they try to put it off as in the public sector as if you stop using this, then everything's going to be great, kids are going to be better. It's just not the case. And so you might solve one problem and cause another. So I think the local dental societies have been also trying to offer assistance when asked, but we don't get asked.
Isn't that kind of crazy?
Right. Yeah.
I mean, that a decision such as that isn't involving the local dental input.
Yeah. That's,
Anyway.
and for us, I hadn't gotten the request from anyone to see what,
share your opinion,
what you think. And so I think then we have to look at it as if, okay, what do we do as parents and practitioners to kind of help our parents make the best decision if it's not going to be something that's readily available? And a lot of people are filtering drinking water anyway. They drink bottled water only. And so there's been a marked decrease in its effectiveness over the past 10 or 15 years. But decay has been reduced in the United States by 60% in the last 50 years with the mere introduction of fluoride in the water. I don't think there's been any radical change in kids' diets. And I think M&Ms and Skittles still sell at a high rate. But the difference has been that fluoride's been in most water supplies. And so I think that's been beneficial. I think removing it is going to prove to increase the incidence of tooth decay in all these communities where it's happening. The problem is it's not going to happen for a while. It's going to take a while because fluoride's most effective during the developmental stages of tooth formation. And that's going to be
just to pause you there, because you're really making the distinction, fluoride supplementation in water as opposed to topical fluoride in toothpaste. The supplementation in water is mainly beneficial in the development of the tooth.
That's right. Because you ingest it in small amounts.
That's right.
And it's built into the tooth enamel as you're developing your teeth. And also a small amount when you're drinking it or brushing it, but it's not like there's enough, concentration of it to be a mouthwash. It's
acting more systemically than it is locally, topically.
And it's both, but it's in the clavicular fluid and things like that. But so I think that understanding that you still can get it through bottled waters that have it. Nursery water is one option. And if you just have some access to that, you'll probably do fine. I mean, and how much do you need? Well, just have a bottle of that and use that for some of your drinking water and get some exposure. Now, there's also the halo effect that we talk about getting. If you filter your water at home, your school might not have a filter. But now if they take it out everywhere, you're going to have a lot of people that were getting it with the false assumption that the reason they didn't have tooth decay is because they're lucky or had good genetics or brush really good. And some of them that's the case, but there's going to be a large portion of it. I don't know what portion it'll be, that we'll find out quickly which ones have been getting the most benefit from the fluoride, because they're going to show the most detrimental effects from
Well,
not
one of the
having it.
sad things about these policy decisions is they usually disproportionately affect the poorest.
Yeah.
And the ones maybe less likely to have regular dental care
Yes.
are maybe affording some of those fluoride extras.
Right. Well, and that's true. And I think that the worst part about that is then it becomes a public health issue, because that population, then the onus of taking care of the problems falls on all of us in
All of us,
society, which,
yeah.
and that's okay. We want to take care of our ones that are most vulnerable, but we want to do it in a way that's prudent, right? And if we can do that with a public health initiative that was proven and shown to be, I know
of prevention or
that,
pound
well,
of
I know at
treatment,
the turn of the century, the World Health Organization, which think what you will of them, had a list of 10
right?
public health advances over the past 100 years, and water fluoridation was one of the 10
Right.
that they championed as one of the biggest advancements in public health that we've had. And so to see it go from that to we're going to take it out of the water is kind of a difficult thing to swallow.
Any trends is the question. I mean, like if someone was saying what trends, I mean, you and I are roughly same age. And so, things such as food allergies and teenage mental health and autism, these things that are dramatically more part of our day-to-day conversations than it was 25 years ago. What are trends in pediatric dentistry?
Yeah. So a couple of things. I think number one, the biggest one has to do, in my opinion, with treatment modalities for tooth decay. Because remember, tooth decay is still our biggest issue. And so I'll start with that. And I think that now, if we can assume that a vaccine's not coming to save the day, which, 30 years later, I'm still waiting, we have to find the most conservative modalities to bring teeth to their full function. I'm great at fillings 27 years later, but my filled teeth are not nearly as good as God's perfect teeth that he made. And so if we can get to these lesions through imaging, artificial intelligence stuff that can maybe map out an x-ray and detect a difference in shades of gray on a thing to maybe tell us that there's an issue here before we can even see with our naked eye. And then delivery modalities on how we might be able to get something to that lesion that would actually impact its effectiveness in remineralizing are the most exciting for me. So actually two ways now, silver diamine fluoride. I mean, colloidal silver has been used in medicine for hundreds of years. And now in dentistry, we finally figured out that if you have a colloidal silver liquid with a fluoride base in it, you can arrest a lesion, have the karyostatic or bactericidal benefits of the silver, also assisted by the hypermineralization properties of the fluoride, and we can actually arrest lesions now. And so I'm actually treating things differently than I did when I was in.
And that's applied how?
That's applied with a brush or with floss and getting it to the lesion. And so the one drawback to that is that it still is somewhat dependent on making dietary changes and hygiene changes and all that. But there's no doubt it's effective, particularly in pediatric dentistry, when let's say you have a 9-year-old who's got a cavity in a tooth that he's going to lose at 11. Well, that used to be, okay, we can either take it out or fill it or just wait and hope it doesn't get tremendously worse. Well, now we have an interim step, and it's a much easier step, and it's applying a silver diamine fluoride to it, killing the bacteria, strengthening what enamel is left there, and having them change their behavior so that lesion can then be basically mummified until the tooth falls out.
Is that like a supercharged sealant?
No, because you're not sealing the tooth. You're leaving. Let's give you an example. There's a hole in your tooth, okay? And so the race is on. When is he going to lose that tooth versus when is that cavity going to hurt or be a problem? If you seal over it, it could still fester underneath. The bacteria is still alive. Microscopic leakage would lead to bacteria continue to proliferate. But if you kill the bacteria and then you talk about mineralizing the enamel around it, you still have a pothole, but now you have a pothole that's solid and not a cavity that's soft and gooey and full of bacteria. But you speaking of a sealant, it's a great technique because if you do the SDF first and then come back several weeks later and then seal over it, you could possibly get the best of both worlds. So we'll use that technique to bridge a longer gap. So in other words, the SDF might not work for 3 years, but if we do the SDF and then seal it, now that might work for 3 years. But if you got that long, you might need to fill it anyway. So just take the decay out and do that. But if you have a population that you can't do that on, let's say an infant who won't sit still and a parent who doesn't want to put their kid to sleep to fix a tooth, then it serves as a great way to kind of delay a definitive treatment without allowing it to progress. Second thing is these treating of actual lesions within enamel or even within the second layer of tooth, the dentin, in permanent teeth before they cavitate. Once a tooth has a cavity that's a hole, it is generally accepted that you have to fix that on a permanent tooth. But it goes through 2 stages before it gets to that. A white spot, and then it turns into a brown spot, and then it turns into a hole. So now with white spots and brown spots, we're trying to get to them and infuse them with, they're using these hydroxyapatite peptides now, which are very, very new. It's a newer way or technology. And in essence, what we're doing is we're etching that surface of that tooth to open up the enamel pores and then scrubbing this peptide, hydroxyapatite peptide into it. It's a liquid, almost like on a mop, like on a brush. And it spends 5 minutes in direct contact with it being dry. And, you keep that area free of saliva for 5 minutes while you isolate it and do it. And this has shown incredible promise because you're actually taking a tooth that used to be drilled and filled. Like that's what used to be the treatment for that. And actually turning them around and making them not have to be drilled and filled. And that is the sweet spot in what we're doing. Identification early on and then treatment early on that's non-invasive because then you got a full tooth. The problem with a filling is that 20 years later, that's a crown. And then 10 years later, it's a root canal. And then it's a bridge or an implant. And so the cost of not having to drill that tooth for the first time could be really, really impacted by this type of treatment. So that's something new. There's only a couple of companies that are making the product that's out of Curodon's one of them. And so it'd be interesting to read for those on the nerdy side,
All right, I've got some rapid fire questions to end.
Go.
These have nothing to do with your clinical acumen, but you just got to give me your answer as quick as you can think of it, okay?
Mm-hmm.
You got it?
Got it.
All right, which is going to be greater? The amount of money LSU is going to spend on NIL football players this year or the amount of money you're going to spend on weddings in your lifetime?
Yeah, I would say NIL for LSU.
Okay, you think
but it's going to be close.
Okay, all right. Who's done more harm to what TV dentist has done more harm to the image? Would you say Dr. Tim Watley in Seinfeld or Commissioner Jam in Parks and Rec? Or you have no idea who I'm talking about?
I don't know either one of those.
Really? You had too many kids. You weren't watching TV.
I was busy.
What's your official dental stance on Halloween?
Yeah, I love Halloween. People
Yeah?
ask me, do you pass out toothbrushes? I said, no, I pass out toothbrushes every day. I pass out candy on Halloween. So no, I love Halloween just because the kids dress up.
Nothing you would change about Halloween. Keep it as it is.
Nothing at all.
No particular candy
All
you would say,
Hallows
just
Eve.
avoid that.
No, because it's an episodic thing. I tell
Okay.
them though, the next day, you probably should be thinking about
Halloween's
getting rid of
over.
everything. It's
Yeah.
over. Let them have it for breakfast the next day. But after that, say goodbye.
Favorite Louisiana hot sauce?
Yeah, actually Crystal.
Okay.
Yeah.
All right. Last question. If you thought of yourself like a professional golfer and you had to have 2 or 3 sponsor brands in your office when you went to see, who would Troy King have on there?
As my professional golfer sponsors.
Well, as a dentist though, I mean,
Oh,
where
yeah.
you got a Crest hat or you have
yeah. I see what you're talking about now. So, well, number one, Glow.
Glow.
So Glow is actually a brand of in-office whitening products,
Okay.
but I just like the name Glow because
Okay.
it's like, who doesn't
Yeah.
want their teeth to glow,
Cool.
right?
Yeah.
So that'd probably be right on the front of the
Glow.
hat.
All right.
And then if I had to, the second one, you know how kids come in, they have their iPods or whatever in these
Yeah,
little
yeah.
white cases and they have them on
Yeah.
their belt right there. Well, I would have floss in that because I always ask them when they come in, they sit down and go, oh, you got your floss with you. They go, no, that's my AirPods. I'm like, oh, okay. I thought you were carrying your floss around
So
with
you have
you.
some.
So I would have one of those. It'd be probably, I like, floss that's kind of yarny. And so there's a Johnson & Johnson brand that's like that. And then my third would probably be socks. It would be socks that had, on the socks, I would have probably Invisalign type teeth on there, because a lot of the kids are interested in 12, 13, 14. They think about braces, but they want Invisalign.
Yeah.
And I think Invisalign is pretty cool.
Yeah.
So it's kind of I think that would appeal to the younger crowd.
Have you reached out to these companies to see
And
if
I
they're willing
would
to
have
pay
my
you?
socks up high like this so you could see them too. I'd wear that. No, I hadn't done that.
Yeah, you
but,
should maybe do that. Well, Troy, you have been such you're a great guest, but also even more importantly, you have cared well for so many kids in our community for so long. Part of that means you're older, but in all seriousness, you have cared so well. And I personally appreciate it. Our patients appreciate it. And great job. And thanks for doing so.
Well, it's a pleasure to treat the population of kids that you send our way. And certainly we get a kick out of the story that you tell them is like, you want me to go where to go to the dentist?
Right.
And they go, just go. And they come and they go, now I see why. So I appreciate him sending me over here. So I thank you for the confidence you give us, and for the parents, thanks for trusting us with your kids. I mean, I know Dr. Middelton can tell you that it's a great compliment when you trust us with your babies, but it's an even greater compliment when you come in with them when they bring their kids to us. And that's
right.
happening now, and it's really kind of spooky and creepy.
That's great.
It's like, how did that happen? So,
Well, great job. And thanks for being with us.
it's a pleasure,
Yeah.
Michael. Thank you.